Cover test. This video will demonstrate how to detect a manifest squint in an adult. The cover test is the most accurate and reliable method of detecting a squint. It is a simple test that requires a minimum of equipment but takes practice and requires close observation. The majority of patients will be children, and the challenge is to gain and maintain their attention and cooperation. The patient should be seated, and you should position yourself in front of them at eye level. If the patient is a child, they may be happier sitting on their parent's knee. The room should be well lit and free from distraction. All parts of the test should be carried out with and without glasses if they're worn. Take a few seconds to make some initial observations. Is there any noticeable asymmetry in eye position, or are there any other abnormalities such as ptosis or pupil differences? Next, hold a pen torch at 33 centimeters from the patient in the primary position, straight ahead at eye level. Observe the position of the corneal light reflexes. If they are central or symmetrical within the pupil of both eyes, no squint is present. If the reflexes are asymmetrical, this indicates that a manifest squint is present. If the reflex is central in one eye but is displaced nasally in the other eye, this suggests an exotropia. If the reflex is central in one eye but is displaced up or down in the other eye, this suggests a vertical squint. Now we can move on to the cover test. When using the cover test to detect a manifest squint, always look at the movement of the uncovered eye. If the patient wears glasses, test first with glasses and then repeat without. Hold up a detailed fixation target at 33 centimeters from the patient in the primary position. This should be a small picture, letter or toy to ensure that the patient is fixing steadily and is accommodating fully. Ask the patient to look at a detailed point on the target. If asymmetrical corneal reflexes have been noticed, cover the eye that appears to be straight and watch for movement of the uncovered eye. If the eye moves out, this is esotropia or convergent squint. This is an example of right esotropia. Note the behaviour of the right eye when the cover is removed from the left eye. In this case, it reverts to the original position, and so it is a unilateral squint. If the eye moves in, this indicates exotropia. If the eye moves up, this indicates hypotropia, and if it moves down, it indicates hypertropia. If there is no movement, this indicates that there is no manifest squint in that eye. If the eye is blind or there is very poor vision, it may not move to take up fixation, or fixation may be unsteady. A child will object to the occluder and may move the head in an attempt to see around the cover. Remove the cover so that both eyes are now uncovered, and the test is repeated, this time covering the other eye and observing the movement of the uncovered eye. The test is then repeated looking at a target placed at eye level 6 meters away. A letter on a Snellen's chart or a small picture is ideal. The cover test is the main diagnostic test for detecting a squint. It is important to test at 33 centimeters and 6 meters, and with and without glasses if worn. This will determine the direction and size of the squint, and also highlight the characteristics of the squint. Some squints will be present constantly and may be uniocular, always using the same eye for fixing, and some will be alternating, swapping fixation from one eye to the other. Squints can also be intermittent, manifest at one distance and controlled at another, or manifest without glasses and controlled with glasses. All children with squints must have a full ophthalmic examination and cycloplegic refraction. Childhood squints can be caused by cataract, retinoblastoma or refractive error. Early detection and treatment is essential.